Yes, Assalamu alaikum, everybody. Welcome to the Islamic Psychology panel. Today, actually, I think there was a mistake on the title. It's actually not supposed to be named Islamic Psychology panel, but rather a more specific title, and that is Traditional Islamically Integrated Psychotherapy, which is a model of psychotherapy drawing from Islamic principles and traditions, an integrative model. And we're not going to be presenting the actual model, but really talking about its development, its past and current development. So we're just talking about where it's at in terms of its trajectory and its being sort of a utilization and subjects that we're applying it to, inshallah. So we're going to start with Sena Aykan, who is actually also with Khalil Center, but situated in Turkey. So she's going to be joining us from Istanbul, Turkey, and she's going to begin the first presentation.
Assalamu alaikum. Can I share my screen? Can you all see my screen?
Yes.
Okay, great. Bismillahirrahmanirrahim. I'm so excited to be here. This is my first time in Muslim Mental Health Conference. Let me start off by briefly introducing myself and then skip right into my topic, inshallah, because I have a very short amount of time. I'm Sena Aykan. I'm a master's student in clinical psychology. I'm also working as a research fellow in Halil School of Islamic Psychology. So today I will be highlighting a couple of topics. I will first start off by explaining why we need an Islamically integrated mental health care when working with clients. And then I will move on to introducing Halil Center, our aims in Halil Center, the therapeutic framework we have developed to work with Muslim patients, which is called Traditional Islamically Integrated Psychotherapy, and finish off with its global impact, inshallah. So why should we adopt an Islamically integrated mental health care approach when working with clients in the first place? So there are many answers to this question, but I will be highlighting a few important research regarding to this issue. An important study conducted by Inayat shows that many Muslims do not seek mental health care because of cultural interest issues. Inayat in his study identifies main concerns that Muslim clients have, such as fear of treatment, not trusting mental health professionals. Most patients feel like mental health professionals have their own agenda and it's not necessarily about their well-being. Clients fear racism. For example, in a study, again, done by Inayat, it showed that a male client explains that he felt being judged by his therapist because he is Muslim, so he is expected to be violent. There are, of course, language barriers where it's hard to understand the other person's accent and what they're saying, and other difficulties in communication and cultural issues where Muslim clients might feel uncomfortable because the therapist holds their hand or lean towards them to make them feel better, which usually backfires with a Muslim client. Or a client uses an expression to shed a light to their experience, and this is not understood by the therapist because he or she is unfamiliar with that expression or the overall cultural context the client is raised in, which goes the same way for religion. Clients who are religiously informed express that they're uncomfortable with a therapist who's not from their own religion or who's not religiously informed. So all these factors and many more cause Muslims to be more reluctant in seeking mental health treatment relative to other groups. However, we know that Muslims do seek help. In fact, after 9/11, there has been an increase, especially in the US, in seeking out help for mental health related issues. But because of everything I just mentioned above and many more, people hesitate to seek that help from mental health professionals and instead this time turn to Muslim clergy and scholars of religion. Unfortunately, only few have any formal training in mental health care, and this creates a concern about the efficacy of solely using traditional healing methods such as praying, doing zikr, waking up for tahajjud, stuff that have actually been proven to be very beneficial for mental health, but do not provide enough help in the context of mental health care. Another survey study shows that Muslim patients prefer religiously understanding therapists and ask religion and spirituality to be integrated into therapy sessions. In fact, more than half of the patients would like to talk about religious and spiritual concerns in therapy sessions. There's also significant data to suggest that Muslims are among some of the cultural groups that benefit greatly from a psychological stance in therapy that integrates Islamic spirituality, which makes it very important and necessary even for an Islamically integrated mental health care approach when working with clients and spiritually oriented mental health care practitioners who are informed by this Islamic tradition, which is exactly what we aim to achieve in Halil Center and the therapeutic modality that we adopt, which is known as TIIP, Traditional Islamically Integrated Psychotherapy. So who are we and what do we do? Halil Center is a psychological and spiritual community wellness center advancing the practice of professional psychology, primarily rooted in Islamic principles. And it is designed to address the widespread prevalence of social, psychological, familial, relational, and spiritual issues of Muslim communities. And I'm going to briefly talk about TIIP. So as I've mentioned, TIIP is a faith-based treatment modality we adopt when working with our clients in Halil Center. It's mainly a therapeutic modality that integrates Islamic tradition into clinical care. Our first publication was a journal article that was published in 2013 and outlined our framework. When Dr. Hooman and Dr. Haq published this article, their central argument was that the important role that Islam plays in the lives of Muslims call for more Islamically integrated methods of approaching psychological treatment with this group. And since then, we have been continuously doing research in our department of School of Islamic Psychology that brings together an interdisciplinary team of researchers and experts to develop this framework. So the TIIP model offers a framework for integrating contemporary behavioral science into an Islamic framework. It conceptualizes and provides a discussion of the nature and composition of human psyche, its drives, the understanding of health and pathology, mechanisms of psychological change, and the principles of healing and psychological well-being. As I have mentioned, our framework comprises contemporary behavioral science as well as inherently Islamic approach. So we adopt an inherently Islamic approach that is inspired by the Quran, the Sunnah, and the traditions of the scholars, particularly of the spiritual sciences of Tazkiyah al-Nafs, purification of the soul. And we also adapt and integrate mainstream interventions that are consistent with the foundations and principles of TIIP. So this is not a model that solely adopts an inherently Islamic approach or one that is based on a mainstream foundation, but brings together the best of both worlds. So what's the impact of TIIP model? There currently exist few training programs internationally, specifically designed to provide professional training to work with Muslim populations. There are also few places in the world that provide such a training, and Halil Center is one of them. Our TIIP model, the foundations of which were laid in 2013, became international in a short time. Over the years, we have had the chance and the honor to reach out to thousands of people around the world, not just as therapists through online and face-to-face therapy sessions, but also as teachers who aim to educate the community and students of psychology through workshops, online trainings, internships, and professional education. We have had a 6-part series on Islamically integrated psychotherapy, which was attended by over 500 people across the world, which we have received many great feedbacks from, alhamdulillah. And we have started training mental health professionals in TIIP in the last years, which also have been receiving a great deal of attention. We have had trainees attending our program from the US, Turkey, India, Pakistan, Canada, England, and other European countries. We have had the first level of our training last summer in Istanbul Süleymaniye Madrasa, and we will be offering both levels this summer too, inshallah. So anyone who is interested in the certification program, I believe the registration is still open. In the meantime, we are continuing to give professional education to graduate students. We are in collaboration with Ibn Khaldun University's Center of Psychotherapy Research in Istanbul and with Ripah University in Pakistan, which allow us to reach across the globe when we are teaching TIIP. I think it's also important to mention that in Halil Center, we do not only provide professional trainings for mental health practitioners, but also aim to educate and help community members according to their mental health needs. We recently collaborated with NYC Mayor's Office of Community Mental Health to develop a workshop designed for Muslim New Yorkers who have suffered grief and loss and who are going through bereavement. And we have also given community responders trainings to the Muslim clergy around the world to help them identify the mental health needs of Muslims, help them better respond to crises, and aid them in seeking further professional help. And we just recently redesigned this training, collaborating with Ibn Khaldun University in Istanbul, to adapt it to the needs of Uyghur community members who have been exposed to war, trauma, and genocide as a nation and forcefully migrated from their own country to start a new life in Turkey. Over the years, we have had many publications and APA symposium presentations where we introduced and highlight the intersection between Islam, psychological well-being, and psychotherapy, which I would encourage all of you to check our website if you're interested in this topic. We have a published book called Applying Islamic Principles to Clinical Mental Health Care, which outlines the TIIP model and serves as the primary textbook for our model. And we will also be publishing an upcoming APA publication on spiritually integrated psychotherapy soon, inshallah. I hope that I didn't overrun my time, but that was all I was going to say. Thank you all for listening, and I'm going to leave it to Dr. Hooman now, inshallah.
Okay, assalamu alaikum everybody. Alhamdulillahi wahda wa salatu wa salamu ala man la nabiyya ba'da. Thank you very much, Sena, for the overview and wonderful kind of synopsis of the work that we're doing. Very well done, mashallah, in a short period of time to be able to cover so much ground. What I wanted to do today is to really talk about the empirical basis of TIIP, of traditional Islamically integrated psychotherapy. This modality, as Sena had spoken about, has been around since 2013, that has been in continuous progression and development until it finally culminated in the 2020 textbook publication, and then trainings and dissemination have formally begun thereafterwards. Some of the things that I wanted to talk about is where is TIIP going from here now? Because as you'll see, I'm going to talk a little bit about the literature, but as you know, we're at a mental health conference at a Ivy League university, at Yale University, at in the School of Medicine, actually in the building of the School of Medicine. And so empirical basis and evidence for your work and your models of care are important. Of course, as Muslims, we don't want to overemphasize, empirical evidence, because we know that in an integrative model, some things may be beyond the scientific method, right? Especially when we come to spirituality, the issue of spirituality. And so some things may be beyond science, but never against science, right? And so whenever we're using evidence, we have to ensure that we appropriate it properly and apply it to the appropriate place. But we do want to talk about outcome studies to make sure that what we're doing is actually helping people get better. And that's really important, to show that your modality is actually effective in making the claim that you are treating psychological and mental health disorders. And I'm going to talk a little bit about the evidence on spiritually integrated psychotherapies generally, and then talk specifically about TIIP and what we're doing in order to ensure that we can evaluate our modality as well. So first of all, empirical studies have demonstrated, first of all, that spiritually integrated psychotherapies are effective in reducing depression and anxiety. And it's more effective, in fact, than a traditional non-religious approach utilized with religious clients. So a secular approach of is inferior to, say, a spiritually integrated approach with religious clients. Other data shows around with CBT, for example, CBT, when it is used with religion, is just as effective for clients in outcome studies, but in 3-month follow-ups, it's shown to be even more effective with religious clients in particular. So religiously integrated CBT was just as effective and more effective, in fact, with those who are religious. Now that a lot of the evidence that we do have is with reference to adaptations of current modalities, meaning spiritually oriented psychotherapies, otherwise known as SOPs, are not, you have very limited data, meaning that the data is just emerging for that. So there's CBT and there's RCBT, religiously oriented CBT, and there are manuals for this. There's Muslim, Buddhist, Christian versions of these. These are mainstream models that have been culturally and religiously adapted. Now, what about an exclusively spiritually oriented approach? Not just an adaptation of mainstream modalities, but rather an inherently spiritual approach, a different model that is spiritually integrated. There's evidence for this, but it's limited, meaning that there is evidence to show that it's clinically effective and that they outperform the control group in studies, and gains are maintained at follow-up. However, the database is small, and SOPs have no evidence. Some SOPs at least have no evidence, and no SOPs meet the strict criteria for specificity, meaning do they work better than alternative groups? So they work just as effective as alternative groups. So this is what lays the ground for what we want to do, or what we did. So despite the fact of the growth and international research in Islamic psychologies, there are currently to date no outcome studies that have been demonstrated that demonstrate empirical basis for an Islamic framework of psychotherapy. So in a publication that we actually put together in 2016, we also demonstrate that there's also an underrepresentation in the literature of specific ways of working with clients from an Islamic standpoint, an Islamic framework. So this is where we get this study that comes together, which is we were part of, Khalil Center was part of a multi-site study led by Bridget, what's called the Bridges study. And the chief investigator of this Bridges study was Scott Richards at the Brigham Young University. And what they wanted to do is to explore spiritually oriented psychotherapies. Remember, I said spiritually oriented psychotherapies as a model on its own, not an adaptation of mainstream models, has limited data. And so they want to do something about this to create a big data set to actually evaluate different spiritually oriented psychotherapies. And we did the Islamic model version of that. So they had Christian models, they had Buddhist models, they had, different kinds of models out there that are not just adaptations of mainstream modalities, but they're standalone frameworks on their own and methods. And they wanted to demonstrate that spiritually oriented psychotherapies on their own as a big set are effective. And so they had 22 centers that employed a naturalistic process outcome study, or otherwise known as practice-based evidence modalities. And I'm going to talk a little bit about that, but the main to create a large data set to demonstrate support for spiritual psychotherapy. So here was our research aims. The research aims for us was to take a spiritually Islamically integrated psychotherapy model, i.e. TIIP, and to see whether it would be effective in addressing and reducing psychological distress and increasing functioning, okay? And the second thing that we wanted to do is to demonstrate as well that by using an Islamically integrated approach, you will naturally increase religiosity as well, and religious and spiritual coping. And then we wanted to see whether this religious coping that we utilize, right, that this model increases spirituality, and that by increasing spirituality, you mediate the effects of psychological distress, meaning that you can explain reduction or increase in psychological distress by increasing or decreasing spirituality and religious belief. And then the other goal was to identify whether there are any specific Islamic techniques that were promising in being particularly effective in this process, which is the benefit of process outcome study that explores the process of psychotherapy as well. These were our research questions, right? And in the interest of time, I won't go through them. It's basically what I just stated in the aims in the form of questions. Here were our hypotheses that the usage of spiritually Islamically integrated psychotherapy will correlate with increasing religiosity or experienced spirituality. And there were two measures that we had for that, that is psychological coping and experiential religiosity. And that experiential religiosity and psychological coping or religious coping will mediate the effects on psychological distress and functioning. And lastly, which is perhaps the most important hypothesis here, is that usage of an Islamically integrated psychotherapy will reduce psychological and functional distress, which is the evidence that we want to show. What's the methodology that we use? Many people are familiar oftentimes in these settings with RCT studies, randomized control trials, right? And we did not choose to use an RCT trial. Part of the reason for that is very expensive, first of all, and has a lot of controls that are necessary and resources. That's number one. Number two, there's also critique about the usage of RCTs in practice, in clinical outcome studies, process outcome studies, that is. Why is that? Because many people who are critical of an over-reliance on RCTs say, and this is the claim of practice-based evidence, which is sort of an alternative way of looking at evidence, clinical evidence. They are critical in saying that it does not produce, RCTs do not produce generalizable findings to the clinical settings or practitioner settings. Why? Because they're over-manualized and they create an artificial environment and setting that is largely in the control of researchers rather than clinicians, right? And so though there is certainly, I'm not one that is completely against the RCT. I think it's important to have RCT literature, but for our purposes, we adopted the practice-based evidence, which is more naturalistic. What does that mean in a naturalistic setting? This means that what we would be doing is that we would be collecting data as usual in psychotherapeutic practice. So we're using Islamically integrated psychotherapy, which is a transdiagnostic model of psychotherapy, which means it cuts across different diagnoses to the exclusion of severe bio-based pathology, right? And what we do is that when somebody comes into the clinic, we take everybody and we include them into the study naturalistically. And that all the therapists that are part of the study will be the chosen and selected individuals, and that they will be they would have had some sort of training in the modality that they're administering. Okay, and so this creates a little bit more of an organic way of just treatment as usual. And one of the things that we do is that it allows, one of the advantages, it allows quicker data collection and greater applicability of the findings. And what you also do is to actually, which is unique to the process outcome study modality or the PBEs, is that you actually give measures after every single session. And the therapist does a inventory checklist as to what it is that they utilized in psychotherapy, what interventions they utilized. And then and then the client or the patient also does a measure of psychological distress and some of the things that I'm going to show you that we did. And so the benefit of this is to see if there are any particular interventions that seem to have particular effects in the psychotherapeutic process that we see reduce or explain some of the distress. In our study, we had 2 males, 3 females as clinicians. These are the measures that we utilized. And I'm just going to kind of, these are some of the demographic data of the patients that we had, predominantly office that we had served, 107 patients, 449 sessions, and this is religion was about 95% Muslim, and 94%, 93% Sunni, some Shia, and they were, majority of them were employed, meaning that they were they were not severe in their functioning. You also want to let in the individuals that were routinely. And 95% of them said that religion was very important in their lives. Here's some data points that perhaps have built a little bit of the suspense for you to see what is the actual outcomes of this study, right? Because we said that we're exploring the efficacy of using traditional Islamically integrated psychotherapy. Well, the only thing I can present to you, unfortunately, today is the descriptive data, because the outcome study, in order to make it publishable, I can't present the data at a conference, unfortunately. So it's prohibitive in order for me to be able to do that. But I'll give you the descriptives, and then I'll leave you in suspense for you to read the actual study when it's published, inshallah. And if you talk to me on the side, maybe I'll tell you unofficially. But I didn't say that. So here's the counseling topics that came up. This is as a result of the therapist checklist that they filled out: self-esteem, marriage, family of origin, employment, a lot of the stuff. And then here were of the patients, which I'll jump through and I'll get to this. Here were the spiritual interventions that they checked off utilizing. And this is in order of, you can see the frequency of usage. So discussing hope, compassion, self-control, gratitude, encourage listening to the heart, identified pathways to God or the sacred, discussed forgiveness, discussed goal set, striving, mujahada, explored religious questions and doubts, discussed and encouraged positive thinking, otherwise known as husn al-dhann, etc. There's a bunch of these that you can kind of see that we utilized. Oh, that was supposed to be hidden, that slide. I don't know why that came up, actually. It's interesting. Yeah, that's it, actually. Those were the descriptives because the slides afterwards actually have the outcomes on them. And so what I'm going to do is to actually hand it off now to Dr. Samar, who's going to be presenting online, inshallah, on TIIP's application to Waswassa and OCD treatment.
Assalamu alaikum. I will share my screen and start in a few seconds. Oh. All right. All right, my screen's up, right? Just to make sure.
Yes.
All right, Bismillah ar-Rahman ar-Rahim. So I'm going to continue the conversation around traditional Islamically integrated psychotherapy with a specific lens on how it applies to religious OCD. All right, so a brief reminder and refresher on what OCD or obsessive compulsive disorder is. It is a mental illness that's characterized by obsessions that are intrusive, recurrent, and persistent thoughts, followed by compulsions, which can be actions or behaviors or even mental actions that are intended to relieve the distress that's caused by the obsessions. And approximately 25 out of about 1,000 individuals globally are struggling with or have struggled with OCD at some point. It can be very distressing. It can also interact with religious beliefs and practices to produce religious OCD, or what we call scrupulosity. So scrupulosity is the term that is used to refer to religious OCD. And when we talk about scrupulosity, we're talking about it in the context of Islam. So scrupulosity is characterized by pathological guilt or obsessions associated with moral or religious action. It's often accompanied also by religious actions. So the compulsions are also generally religious or moral thoughts or actions. And it can be very distressing to individuals, particularly that OCD. So OCD in general, individuals who struggle with OCD tend to have anxiety because there is this perceived irrational at times or exaggerated fear that they're trying to avoid. And with religious OCD, the stress and the stakes are even higher because that ultimate fear that that they perceive that they might be heading to is eternal damnation or heading to hell. So it can be very consuming, very distressing to individuals. It's also been clinically described as a state of fearing sin where there is none. So if you look at individuals who are struggling with scrupulosity, their symptoms will fall into one of 5 types of scrupulosity or categories. Either cleanliness, which has to do with tahara or purity, can be physical purity, purity of thoughts or intention. It can fall into the category of prayer and salah, which is very ritualistic. So in terms of the number of units that they prayed, maintaining the sanctity of their prayer. Was their prayer good enough? The other category has to do with marriage and divorce. So an individual might think or read the word divorce and think about their spouse at the same time and wonder, does that count as a divorce? Is our relationship or marriage nullified? The fourth category, it has to do with character. So individuals might struggle with intrusive thoughts around, let's say, have sexual thoughts or violent thoughts and question what that means about their character. The last category is fear of apostasy or OCD or scrupulosity that is related to aqidah. And that has to do with intrusive thoughts that can relate to, a person thinking about blasphemous thoughts related to God or faith. So they will feel very distressed and wonder if they left the realm of Islam and aqidah and if they have to renew their faith. All right, so religions in general and Islam specifically, there's a lot of rituals and practices and discipline and practice. And we are encouraged to maintain a pure intention, to execute our acts of worship with excellence. So how do we differentiate between scrupulosity and devout religious practice? It's a very important line to distinguish. So, and the key differentiating factor is that individuals with scrupulosity tend to engage in acts of worship with a focus on relieving their distress. That is their focus. They usually are very distracted. Their concentration in prayer, for example, is consumed by relieving the distress and engaging in actions in a way that relieves their distress rather than fostering an intrinsic spiritual experience or closeness to Allah. And a lot of the time they would tend to disregard other religious rulings or knowledge or information for the sake of relieving their distress. All right. So where do individuals who struggle with scrupulosity go? So as Sena mentioned earlier, there's a huge gap where a lot of individuals who are struggling with Muslims who are struggling with mental health issues tend to shy away from going to traditional or secular, Western packaged therapy or treatment modalities, and will either not seek therapy at all or treatment, or will go to religious scholars or religious imams to get treatment. Because scrupulosity is, it's a mental health issue with religious manifestations. So they might go and try to get the religious aspect addressed. And if the chaplain or the clergy is not familiar with mental health, they might end up providing, addressing a piece of the picture, which is not addressing the whole issue and sometimes might exacerbate the mental health issue. Because some individuals with scrupulosity might go, fatwa shopping or going to different clergy to find reassurance. So there is a need for an integrated treatment approach, and that is where TIIP comes in. Let me try to go to the next slide. There we go. So traditional Islamically integrated psychotherapy for scrupulosity. And Dr. Hooman, Dr. Fahad Khan, and Dr. Syed published a chapter around this topic, traditional TIIP for OCD scrupulosity, Waswassa. And the term Waswassa is the Arabic word that is used to refer to scrupulosity. It is translated to whispers. All right. So the primary mechanism of change or treatment when it comes to TIIP and addressing scrupulosity is to restore the balance or i'tidal of each element of the psyche. And this is important to highlight. So I know we're mentioning TIIP, and for some people this might be new, for many it might be something you're familiar with. But when we talk about restoring balance to each element of the psyche, we're looking at it from a TIIP perspective, meaning we are looking at a person holistically, and this holistic view incorporates metaphysical aspects. So we are looking at their spirit. We are looking at the human and the person as a being that's existing and affected by metaphysical factors as well. So a brief graph to look at, what are these aspects of the psyche that we are talking about, that we're trying to restore balance to. So the 4 in the square, there's 5 elements, but I'm going to start with the 4 that are in gray squares, and then I'll go to the heart. So 1 is a person's cognitions, their aql. Then their emotions, which is their ihsas, their spirit, ruh, and their behavioral inclinations, which is the nafs. So when those elements are out of balance, they can affect each other, and they ultimately affect the spiritual heart. So, and our goal is to maintain these aspects of the psyche in balance in order for the spiritual heart to be able to find tranquility and closeness to Allah. So with scrupulosity, person's cognitions are persons consumed by distorted, biased thoughts, dysfunctional beliefs. Their emotions are out of balance. They're overwhelmed with fear and anxiety and guilt. Their behavioral inclinations or their nafs is very undisciplined and unable to control a person's behavioral inclinations to engage in these compulsions. And the spirit at the same time, a person spiritually finds difficulty experiencing that closeness and connection to Allah because they're feeling guilt, they're not feeling hopeful, and they're unable to reap the benefits of the spiritual belief and the practice that they ultimately aim to attain. So I know I'm going through this quickly. I do have a brief time, so I have a few more slides left. But for those listening, inshallah, at the end, we'll have some Q&A to follow up. So I'm going to transition to a little bit of practical steps. So TIIP and Khalil Center. So offer a practical approach to addressing scrupulosity as mental health providers. So myself and a few of my wonderful colleagues, Dr. Khalid Zamzami, Dr. Hooman, Dr. Fahad, and Enes Kaban, came together to develop this workbook focused on addressing scrupulosity from a TIIP lens. And this workbook is for Muslims struggling with scrupulosity, and it's not a self-help workbook. Rather, it's a workbook that is aimed to be a collaborative tool between the therapist and the client. So it's important for the client to be an active participant. It is organized in a way where it's meant to go in sequential matter. So there are 8 chapters, and I will go through them briefly just to touch base on what this workbook will cover. So chapter 1 is an introduction, a lot of psychoeducational material comparing and differentiating between OCD, obsessive compulsive personality disorder, and religious OCD, and referencing also scrupulosity in our tradition, that this is something that is not new. It has been there, there's reference to it. So just kind of getting an understanding of the terminology to share that language. Chapter 2 is a very unique chapter and a very foundational and essential topic to introduce, I think, on a community level, but also in therapy. So over here, we talk about understanding the nature of thoughts and doubts in Islam. So we really focus on the understanding that not all thoughts are the same in terms of their sources. So we have thoughts that can be produced based on our socio-emotional, socio-cultural history. There's thoughts that are rooted in metaphysical sources, such as whispers from the devil. We can experience inspiration from the divine. But also thoughts can differ in terms of how certain we are about them. So there's levels of certainty. There's a little graph over here that's in the workbook as well. And it divides and looks at levels of certainty from our Islamic tradition, but in a way that is applied to this mental health condition as well. So a person's thoughts can be certain, a person can be certain 100%, all the way to 0, which is delusions. And we highlight how the first 2, which are 100% certainty and thoughts that are highly probable, are considered sound and healthy basis to make decisions and base your actions in. And people struggling with scrupulosity tend to be stuck in the latter 3, mainly doubt. Chapter 3 looks at cognitive interventions. We look at challenging cognitive distortions. A lot of the examples in restoring balance and challenging dysfunctional thoughts are, so we provide basically a lot of examples about the religious manifestation and how to utilize cognitive interventions to restore balance to one's thoughts. The 4th looks at behavioral interventions. We start with some relaxation techniques in order to hopefully build a person for success, since they're going to be dealing and triggering a lot of anxiety, engaging in exposure response prevention. However, we utilize Islamically integrated response prevention approaches. So the last 4 chapters, 4 chapters. So chapter 5 focuses on emotional considerations, understanding emotions that Allah, the emotions that Allah gave us and that we experience are something that's healthy, but it's important to differentiate between what is adaptive and maladaptive emotions. We really focus on acceptance and rida, how to foster that, dealing with scrupulosity. Chapter 6 looks at spiritual interventions. So since a person is out of balance emotionally and overwhelmed by fear, we try to focus on engaging and connecting to Allah through the lens of mercy, through the lens of His wisdom, trying to make meaning of one's struggle so they're not stuck in a state of suffering and they're able to progress and find closeness to Allah through their struggle. Chapter 7 goes over maintenance and relapse prevention. And chapter 8 looks at considerations around the role of clergy, medications, and lifestyle. So although we're looking at metaphysical aspects and spiritual aspects of an individual, it's really important to find the right interdisciplinary collaboration with clergy as well. And so last, I just wanted to present and just show you guys the 2 main references that I was referring to in the presentation. The initial chapter that was published, and then the latter is our workbook that's in publication, inshallah. I have my email there, so if anybody wants to continue this conversation afterwards, you can feel free to reach out. it's hard to get it in 7 minutes. I know I went above.
Dr. Samar.
Yeah.
Let's go to Enes, also from Turkey. Now, Enes, are you there?
Yeah, I'm there. I'm here. Okay. Assalamu alaikum jami'an. Can you all see my screen?
Yes.
Okay. Okay. Now what will I do is I will talk about my research project actually for my my thesis project. So the name is the exploring the efficacy of the TIIP in the treatment of scrupulosity, Waswassa. So first I will start with a little bit of introduction. Why do we need spiritual oriented therapies? As Sena, Dr. Hooman and Dr. Samar told, Muslim people do not seek professional help because they look for religiosity, but when they don't see that, they don't feel to go professional help for mental health. And they would like to talk about religion and spirituality in their psychotherapies. So therefore, spiritual oriented psychotherapies are as effective as secular ones. Therefore, we saw that there is a need for spiritual oriented psychotherapies, but that should be integrated with our own teachings. So what will we do is, what is our aim is that explore the efficacy of the TIIP model for the OCD scrupulosity in this thesis project. And second aim is to explore the efficacy of,
Enes, can't see you switching slides.
Okay, I think it's, let me just stop sharing and I will share again. I don't know why. Okay, I will go like this then.
Perfect.
Go one by one. So our aim to explore the efficacy of TIIP's signature interventions and to compare the difference between CBT, which is included which includes cognitive interventions and behavioral interventions with the treatment against TIIP. So basically what we do is we will use our workbook to we will make it to apply to our sessions, and we will use those that book to solve the problems of the people with OCD, especially scrupulosity, and we will try to measure the changes. So the research questions are: what will be the clinical outcomes for the usage of TIIP on OCD scrupulosity? What will be the process outcomes for TIIP interventions on scrupulosity? And how does the TIIP perform in comparison to CBT? So these are our questions, and our hypothesis is usage of TIIP will lead to a reduction of obsessive thoughts, compulsive actions, and subjective distress. And the usage of the TIIP will produce equivalent or better clinical outcomes against CBT on OCD scrupulosity. So what will we do as a methodology? We will use practice-based evidence. Why we are doing that? Because it's a person-centered approach, and we want to see the differences in the individual sessions and what help people in that individual session. So therefore, it's since it's a bottom-up process, it has a bottom-up process, we will be able to see those interventions that are most effective in each session, and it's flexible for including cultural and social values for research questions. It's not like RCBTs, as Dr. Hooman explained previously. So also we will have comparison groups. So therefore we will be able to compare our results with well-published with a well-published approach, which is CBT. So we will be able to use the tools of statistics to demonstrate that it's not just our individual applications are important, but also in overall our approach helpful for the relieving the OCD symptoms. So our inclusion criteria is we will use adult population and who has diagnosis of OCD scrupulosity and who are not using medication and there is no who doesn't have any comorbidities. So to exclude participants, we will not work with the adolescents or the children, and we will not work with the comorbidities and other types of OCD, and also we will not work with the severe OCD scrupulosity cases which should use or who are using medications. For the sake of our intervention, we will not use those people. So we will plan to have 30 participants in 3 groups: the TIIP group, the CBT group, which will be control group, and we will have a wait list too to look at the baseline, what's the difference between TIIP approach and the wait list and the CBT. Also, we are planning to have 3 to 5 therapists to carry out the sessions, both in CBT and TIIP groups. Also, we are planning to have up to 12 sessions. According to our book, we will divide our book to do up to 12 sessions, and data will be gathered at every session. So we will give questionnaires to measure their distress and obsessive thoughts and compulsive behaviors after every session. And that way we will be able to see which treatment influenced most, has most influence. So that's all from me. This is my references. Thank you very much for your time and attention.
Okay, so everybody had an opportunity to sort of see TIIP generally in my presentation about TIIP's general application across diagnostic groups. And then we had an opportunity to sort of see how it can be applied specifically to OCD, scrupulosity. And then now we're going to expand that further to a common psychological problem that may also cut across different diagnostic categories, but it's a kind of a marker of inner psychological distress that's very common. And so we're going to have Farhad and Feyzanur from Istanbul, Farhad who's here, who are both doing their own dissertations separately on the notion of the internal critic and the usage of chair work in order to be able to address internal critic. So who's going first? Okay, Feyzanur will be going first. Feyzanur, go ahead.
Can I share my screen?
Yes. You can do it now.
Okay. Assalamu alaikum, everybody. I am Feyzanur. I am PhD student at Ibn Haldun University. Today I'm going to talk about my proposed PhD dissertation topic in the title of Exploring Islamically Integrated Unfinished Business Chairwork for Grief Counseling. To begin, I want to give a little bit information about background for my study. Although people in general can develop adaptation skills over time after the death of a loved one, a significant minority experiences significant psychological problems. One of the significant study, Yamasaki et al. Found that around 30 of the bereaved people show some unfinished business conflict, and they found that a higher level of unfinished business conflict is associated with a higher level of psychological problems and unhealthy grieving. When we look at the unfinished business concept, it indicates incomplete, unexpressed or unresolved relationship issues with the deceased, and generally unfinished business conflict manifests with regret, anger, guilt, or remorse. When we look at a recent systematic literature review conducted by Destapana et al., they found that grief experience directly affected from spiritual, religious, and cultural beliefs and practices. In addition to that, it's known that meaning-oriented techniques are more effective in grief therapy. Although it is known that religion and belief systems have a very important place in a grief therapy, there is no specifically developed intervention for the grieving Muslim population utilizing a faith-based approach in the literature. So our proposed study aims to develop TIIP chair work intervention to resolve unfinished business who experience grief in the Muslim population. When we look at the method part, the research question, first research question is utilizing TIIP chair work intervention associated with a reduction in symptoms of unfinished business in bereaved Muslims experiencing grief? And there is two hypotheses for this question. First one is the severity of the unfulfilled wishes will decline at the end of each TIIP session chair work. And the second is the severity of this unresolved conflict will decline at the end of each TIIP chair work session. And the second research question is utilizing TIIP chair work intervention associated with a reduction in prolonged grief symptoms in bereaved Muslim experiencing grief? The hypothesis will be the severity of the prolonged grief symptoms will be diminished at the end of the chair work intervention. When we look at the methodology, we are planning to use process outcome study. As before, Dr. Hooman mentioned, we aim to develop a protocol to use in a grief therapy. So to measure the efficacy of our protocol, we want to use process outcome study and practice-based evidence study. When we look at the research participant, the inclusion criteria will be religiously adherent adults, grieving for unresolved tension for a loved one minimum 6 months ago, and not use psychiatric drugs. When we look at the intervention procedure, TIIP chair, there will be utilizing TIIP chair work techniques in a 6-session one-by-one treatment plan. The process of change will occur during the 6 sessions and follow sequential 4 phases according to TIIP model. In addition to that, we are not aiming to resolve the grief symptoms, all of the grief symptoms. We are focusing on the unfinished business. On the other hand, to study within the unfinished business with bereaved people, we are also expecting some declines, some resolutions in the grief symptoms, but there will be a focus on the unfinished business. So when we look at the intervention procedure, first session will be focused on the INCIAD in TIIP. So we are planning to conduct the alliance between the patient and the therapist. And the second, we are planning to uncover what is the problem, what is the unfinished something between the bereaved people and the deceased. And during the between 3rd and 5th sessions, we are planning to utilize chair work intervention. And at the end of our intervention procedure, we are aiming to gain balance in the participants. So we are using 2 measures. First one is the unfinished business in bereavement scale, and second one is the prolonged grief disorder scale. And each of the measures will give at the end of each session. So we have chance to see the differences between each session. So we can understand which procedure will be most effective. And also we are planning to use prepare script for each session. So we want to manualize something to explain for other people. And this procedure will be also emotion-based work. And this is for my proposed study. Thanks for your attention.
Thank you, Feyzanur. We're going to have our last but not least speaker, inshallah. Just a clarification, actually, I made a mistake in introducing when Feyzanur. Feyzanur was not talking about grief, was not talking about critic work, rather. There's two types of chair work, right, that we do in TIIP. One is for the unfinished business, which is unresolved conflict. And this is actually when, like in the context of grief, grief is an adaptive emotion, right? When people lose somebody, they feel grieved by the fact that they've lost somebody close to them. The problem is when you lose somebody and you have unresolved conflict, you have regret, you haven't been able to talk to them about something that you needed to talk to them about. There may have been turmoil within the relationship. There may be regret about not achieving certain things that that person may have wanted, or mistreatment of that person to you or you to them, for example, that may be this unresolved conflict. This makes bereavement and grief complicated, and it can turn into prolonged grief, and it can also turn into complicated grief. And in some cases, it can go from grief to clinical depression. And so this is really the usage of this protocol that Feyzanur will be utilizing is in the interest of being able to reduce and hopefully deal with individuals who have complex or prolonged grief as indicated by some sort of unfinished business. And that the hypothesis is that this would have reduced by the end of it. And we're going to have now Farhad, who is in the last stage of his doctoral education here, actually going to be in Connecticut to do his final internship. And he's been with us at Will Center for many years, alhamdulillah. So we're going to have him come up and speak, and he's in person. So I'm just going to pull up his slideshow. You guys see everything on the screen? On your screen? Is everything okay there? Can you just double check?
They see it? Are you sharing your screen?
Yep.
Should be able to.
Are we sharing the screen?
You have the ability to.
Oh, maybe I didn't share the screen.
Whoever your boss has to stop sharing your screen. Yeah,
Assalamu alaikum. It's wonderful to be here, alhamdulillah. There's a huge lineup of amazing studies and researchers, mashallah, and Dr. Hooman with the introduction. I'm just going to take a few minutes to go over this dissertation study. This is the headline version for what will be, inshallah, completing for my doctorate, using chair work and working with shame and self-criticism in a Muslim demographic. Now, shame, self-criticism, these are all ideas that we see throughout, human functioning, and we see, even within ourselves. Maybe there are part of us that, feel a little ashamed. I feel a little ashamed being up here in front of teachers, mashallah, who, are doing such amazing work, but yet we're here, right? And then there might be self-criticism, things that we tell ourselves that, oh man, I should have done a little bit better. I think all of us here are educated, so we've been through tests and exams and things where we felt bad when we got a bad grade. So that is self-criticism, right? That's a brief synopsis of what we're going to be looking at in this dissertation study. So these are just some big definitions, some ways of sort of breaking down what we're going to be looking at as a construct. So shame being this very intense emotion. So that's the affective process. And then self-criticism being the cognitive process. So it becomes a cognitive affective issue. So self-criticism is sort of the negative thoughts, the things that we sort of tell ourselves, and these two main adjectives being used here: harshly and punitively scrutinizing yourself, right? It's almost like what we see from TIIP. You see the nafs sort of creating a critical side of it to make sure that there is an adaptive functioning for the human being. So self-criticism and shame are very closely related. And there's lots of research. I could probably put a lot of references here, but there's a lot of research that shows that these are two very pervasive symptoms in PTSD, in anxiety, in depression, bipolar even. There's lots of different symptoms that we see throughout different psychological disorders. Now, obviously the reason for this study is so that we can find more and more research for Muslim demographics, so that we're not just using whatever studies that are used for maybe white, black, other racial backgrounds, even other religious backgrounds. So we're hopefully, inshallah, through this study, going to find more and more evidence for using this technique, inshallah, with Muslims. Okay, at the top it basically says chair work. I think it's being covered, but there's two chairs. And I want to make this very simple because it's not that difficult. It sounds a little, nebulous when you first hear it. What is chair work, right? It's like talking to a chair. But you have this picture, you have two chairs, and you have an individual, a client, hopefully a client, not yourself, a client sitting in the chair, then that will essentially imagine or evoke a critical side of themselves in that other chair. There's only one person. And if you look at the diagram, you have one person who is working with a therapist, and there might be a marker. So let's say, for instance, I go ahead and I did really bad on an exam, and I feel, man, I really suck. I did such a bad thing, and I'm working through this with my therapist. Hopefully, if he's a good therapist, they will say, you sound pretty critical right now. Let's evoke a conversation. So what is step 2? Enact a critic, right? So we're gonna put the critic inside this other chair and then start a dialogue. So there's a self, the part of you that hopefully is the whole part, and you're sitting there and you're talking to this critical side, that little voice in your head that goes ahead and says, you suck as a person. Why couldn't you do? All your other friends are probably doing really well in class. They're doing a really good job, but you're the only one that's failing, right? And so you're going to have this dialogue, and hopefully through that, transform shame, because shame can be adaptive, right? And this goes into emotion theory, and I don't have that much time. So shame can be adaptive, but we're hopefully trying to unlearn some of that maladaptiveness. And that's where going through a self and critical dialogue will hopefully heal that. And so that's like the pretty much the summarized version of this. We can probably talk about this, and I can show you guys lots of research that goes through it, but in the interest of time, I'll keep it short. These are the main research questions that we'll be using for this dissertation. Essentially, can we see the chair work being an effective intervention for a Muslim population? Self-criticism and shame. And I'm gonna go into some of the methodology, which inshallah will elucidate this.
Sorry to interrupt. Can we have the slides transition on Zoom as well, please?
Oh, sorry about this. Oh, wait. Did that work? Is that, no, nothing?
No, but it's okay. In interest of time, we can listen if it's not transitioning.
Yeah.
Yeah, the other person that stopped sharing the share then that worked for that.
Mhm.
Oh yeah, I can do that.
Okay. Can you see it now?
Yes.
Perfect. Thanks.
All right, great. So we're gonna have. So this is essentially a unique study that's sort of coming up. This particular multiple baseline design is being used more so within process outcome research, particularly for psychotherapy. Psychotherapy, as we all know, it's a very experiential process. It's hard to get a lot of funding and to have so many participants. So this way, we're going to be utilizing a very small sample, only 12 people, and we're going to ensure all their criteria are met: inclusion criteria, exclusion criteria, making sure that they're not already in psychotherapy, making sure that they don't have any alcoholism or any other type of factors that might impede on the psychotherapy process. They're going to be coming in for 12 weeks, and we're going to have varying conditions. We're going to have a weak treatment condition and a waitlist condition. And so there's going to be 4 groups, and basically we're going to use a whole lot of psychometric measures, some of them which you guys will probably remember from school and from other research studies, but we'll use that at multiple points during the process. Essentially, the way that a doctor uses an EKG machine, right? What do? They want to see how your heart is changing and how all your physiological responses to different things. That's essentially what we're going to be doing. Over the course of 12 weeks, have enough data points so that we can hopefully see a negative or a decrease in shame and self-criticism. I have a nice little graphic which Inshallah, we'll make this very easy. So you have 12 weeks, 0 to 4, 4 to 8, 8 to 12. Group A, Group B, Group C, Group D. Group A, if you look at the topmost with the blue line, 12 weeks of full treatment, right? 12 weeks of full treatment. They're not going to be waiting for anything. They're going to just start work with their therapist. Group B and Group C, they have a waitlist condition. If you look, the first box is a baseline. So for 4 weeks, they're just sitting, they're waiting. We're going to be offering psychoeducational workshops so that while they're waiting for their treatment, they'll basically just be getting involved with some very basic educational stuff around anxiety, around self-criticism. So stuff that will just be very, they won't be experiential, so it's not affecting their therapy process. So then Group B will have 8 weeks of treatment. Group C will only have 4 weeks of treatment, right? You can see baseline for 8 weeks and treatment for 4. And Group D will have will not be receiving treatment at all. Now, obviously, we will make sure that these guys will all get treatment at the end of the study. But this is a nice snapshot of seeing what this will look like over the course of 3 months. How in each baseline condition actually serves as a control, so that we're not, instead of having what Dr. Hooman was mentioning, randomized controlled trials, you need to have a bunch of control groups. This way, we're actually utilizing our own participant group to serve its own as its own control, which is very useful. It's great for a dissertation study. You don't have to have too many people. And so, yeah, this is basically the study layout. And I have an assessment schedule, which I know I'm realizing now is probably not the most clear, but essentially there's a bunch of measures. On the left-hand side, you'll see there's a Google form. There's the FSCRS, which is the forms for self-criticizing and self-reassuring. The mini, which is a neuropsychiatric interview. BDI, BAI, everyone should know that. Back depression, back anxiety. DEQ, depressive experiences questionnaire. SCS is self-compassion. ESS is experiences of shame. GASP is guiltiness, shame, proneness scale. And DORS is the degree of resolution scale. So at every 2 weeks, if you see there's a little line that says biweekly treatment assessment, we're going to be giving these measures, the ones that are X'd out, to the participants, and hopefully after every 2 weeks we'll see some sort of change, and at the end of it, inshallah, we'll have hopefully good data, and if not, then hey, we tried our best. But yeah, so that's pretty much it. I appreciate everyone's time. Inshallah, this is basically a small little study, inshallah, this community-wise, and yeah, jazakumullah khair. Assalamu alaikum wa rahmatullah. And I guess Q&A or sure. Oh, yeah, it seems that the transition was an issue for the slides. I don't think there's any particular questions for. Yeah, I believe Sena shared the training. Oh, yeah.
So is the idea of comparing against the baseline this baseline approach? I took the utility of the fact that you can use your own participants with so you don't have to work with more individuals.
Yeah.
Would it, like, let's say you did not have limitations in terms of time or access to the patient population like that. Would is there like something more comparison group? And then the question is, the comparison group, would that be a different modality to treat the same issue? So would it be CBT? Would it be, because it's not a diagnosis that you're treating? You're addressing inner process.
Yeah, that's a great question. So I guess if I'm hearing correctly, if it wasn't just 12 participants, right? If say we had 100, we could essentially use the same layout. We'll have a better effect size, right? Hopefully, the larger sample will hopefully lead to more descriptive and hopefully better data. I don't know if there would be necessarily a better way, given that it's psychotherapy, right? Maybe it's different for popping a pill with a psychiatric drug trial, right? Maybe it's different there. But at least from my research, some of the most recent psychotherapy studies are using multiple baseline design. And that's just because it seems to be the easiest, regardless of samples. There's a recent one by Ben Shahar. He's a social anxiety researcher who basically had 40, 50 people and use the same method, right? And it's useful because like we're saying that there is this control that sort of, the participants to become their own control. But it also gives us, like, you're not using another group. You're just using this to sort of see, okay, well, at week 4, when we already had the participants for group A and group B participants are going in, we see the same decline that we imagine we will see with group A, which sort of, serves that same purpose. So, if we had concurrent groups going on from like 0 to 1, I don't think it would be as effective, right? This at least shows that the intervention is working, which is why I think that there's the utility of multiple baseline design.
The question is like, but if you had a comparison group that was a CBT group, let's say, for example, and what you're trying to say is that this chair work is more effective for treating X syndrome with than something else. But I guess the problem here comparable alternative, like in the case of Waswassa,
Right.
we're saying we have a TIIP model, and then we have a CBT framework that does treat OCD Waswassa specifically.
Yeah.
In your case, you're saying we're not treating a disorder, we're treating an inner process.
Right.
And so there isn't, the other modalities don't really have a discussion of this in our process per se.
Yeah, I get what you're saying. I think if we were perhaps maybe comparing it to like CBT for self-criticism, which I don't know if exists, I guess we would probably see a difference, right, in terms of how you'd structure that. I don't know if there's like more to the question. I feel like maybe but I think it's an interesting comment, right, just to see if maybe this chair work can be.
Would you or could you do that? I guess that's the question. Or are you saying like that not necessarily because you did another language for this? So you can't really compare it against CBT because it's comparing apples to oranges.
At CBT I think would be a little bit harder, right? Because the interpersonal process is a little bit different. Not to CBT people, but it is different, right? Perhaps maybe like I know we were discussing like psychodrama, right? Or if you're using more dynamic approaches, right, relational approaches, because that's essentially what we're doing, right? Increasing the interpersonal process. Perhaps that we can, and then even using, actually that would be interesting if anyone's looking to do a dissertation. It's like you can have one group where they're doing like psychodynamic, more psychodrama based treatment, and then more like TIIP chair work, and basically doing that side by side. That would be pretty interesting, actually. So sorry, I think you were you going to say something before? I saw your hand.
Can I ask or sorry?
Sorry.
So when you were talking about the multi-baseline approach and using patient under our control, do you mean like patients who are not receiving any therapy at first and then started receiving it like halfway through the study?
Yes.
What's the benefit? I can see how that is different than having just a baseline that doesn't receive no treatment, like a complete control group, separate from a group that does receive treatment. What's the benefit of having like a 2-tiered in the middle where you get treatment at 4 weeks and 8 weeks versus separating it into 3 groups? That way you have more numbers in like each group so that your power like kind of for like each group.
Yeah, that's actually a pretty good comment. I guess maybe. Oh yeah. So Brother Abdurrahman is saying why the number of 4 groups, right? Why 4 groups, and wouldn't it be more statistically powerful to have 3 groups in which you have more? I guess you have 4 participants in each condition, which I think is a good point. I don't know if there's any particular reason other than I think what we've seen in the research is that they've done more groups, particularly 4 groups in which they're sort of dividing up the time. I wish I could tell you I have an answer for why they did 4, but I would have to acknowledge my intellectual humility here. But it's something I would love to actually look into, and maybe we can discuss more after the session, inshallah.
Could it just be kind of it's almost like a sacrifice to the calendar of getting in the process element you have more information kind of where in the timeline starting or switching things. And so there's a certain landscape information you're getting, but in terms of power, you're definitely not getting much of it.
Yeah, so keep in mind this is kind of like you're almost chunking the phases across the 12 sections, breaking it up by checkpoints. So instead of 4, sort of let's say 6 weeks in versus 9 weeks in versus 12 weeks in, because like some kind of comparison to understand to compare it. Yeah, you know, saying that giving the first 3 sessions with no change. And but when you compare 12 or 9 weeks, that's when we see the change.
More of a granular micro level of
So, right, slowing down the
sacrificing to your point the power generalized.
Increase and it's up.
right. As we do in therapy, right? We slow things down really, really slow for our clients. I guess we're doing the same thing in the study, basically. Yeah. That's a great question. So that's okay. Thank you.
And the dependent variable is what the outcome we're saying that this is reducing.
Yeah, reducing the levels of reported self-criticism at the assessment, the intake, right? So at the intake where they have to meet a certain criteria. So let's say, 30, right? 30 is self-criticism and 40 shame. If they're meeting that, we're assuming that the same measures, right? We're not changing measures. We'll hopefully be reporting maybe 20 or 15 at the end of.
Which leads to, is there an association of shame with psychological distress?
Yeah, so we'll hopefully have a more adaptive, and this is where it goes into theory, but more adaptive use of shame, right? So that it's not.
Is there a measure for that, or it's drawn from the research?
It's drawn from the measures that we have. So we have like the experiences of shame scale, right? We have the guilt and shame. Yeah. So all the measures, that little assessment schedule that basically is going to track all of that. Yeah. So we're just operationalizing on those measures. But yeah, the hope is that the interpersonal process will slow down, and that those things will heal themselves in the process. Yeah.
By decreasing shame, that's potentially psychological distress.
Right. Okay. Oh, so that's for putting it in here. I don't know if WOVA is being checked. Dr. Keshavarzi, first of all, I love you so much, and I'm curious about any nuances around the process that relate to establishing and maintaining the therapeutic alliance in your study. I think this might be directed towards you. Sure.
Dr. Mahdi, when I saw your name, I asked myself the same question, actually. So
something about love for the sake of Allah that's therapeutic, isn't it?
MashaAllah. So I mentioned, are you in Edmonton?
I am, yeah.
MashaAllah. So for those that don't know, we met in Istanbul of all places, actually, in the summertime. So the question about how to generate, empathic alliance or therapeutic alliance. So it's one of the stages, and we call that murabata, right, which should generate inqiyad in the individual. And that, the short answer is there's a series of empathic following techniques, which uses reflection, as well as evocative reflections, as well as, following alliance building that we're very familiar with, but it's a little bit more with some degrees of specificity in very specific ways. Like an evocative reflection is different than an empathic reflection, which is different than a fit question, for example. And so really what we're doing is to try to, ideally in the early stages, get at not only the cognitive aspect of what's going on in the patient, meaning what they're saying to us, but what they're experiencing as well. So it's more of the experiential layer as well. So we want to, what does this feel like, this experience? What is this? And this is where the alliance is, we believe, is better built by not just staying at the level of the head of the experience, but also deeper than that, which generates that sense of, oh, you really get it. Like you really get what this, because when people come to us, they come to us with not just an intellectual problem that I need you to solve, but they want to make sure that you truly understand the full experience of the problem as they experience it.
Yeah.
So that's kind of, and in our trainings, we actually do some role plays and whatnot to try to demonstrate that.
I was wondering if you used it as a variable in your study. That was the main question.
Oh, I see. In terms in the study that I spoke about.
Yeah.
That if we use it as a variable to the degree of therapeutic lines, I don't think we have. That'd be actually very interesting to do. Does therapeutic alliance mediate the effects of the accompanying interventions that are?
That in common factors research, it's very clear, right?
Right.
So
right.
Transdiagnostic, it's just, and that's, the area that I'm mostly concerned with is establishing that therapeutic alliance, because if that's possible, then when we train lay counselors, imams, at the very least, some akhlaq between them, just, they don't feel like, well, I wish I never went to that, right? Like, yeah, inshallah khair, jazakallah khair. I'm a big fan of you guys' work, mashallah. I have so many other questions, but I don't want to eat up any more of the time. So if nobody asks questions,
invite me to Edmonton and we'll like
100%. Are you kidding? Right now?
Lie.
You think I'm joking? Just give me a second. You gotta. We'll talk though for sure, because there's a lot more, inshallah. But this is excellent, mashallah.
There's a couple of other questions here, or we couldn't hear what Mr. Keshavarzi said. Could the presenter sum it up for us? Oh, did my sound not come through, or?
No, I think that might have been.
Oh, I see. I think it was in the question. Oh, I was asking, I think Farhad answered these questions. I was asking about why not having, say, like a CBT group? Is it because we're looking at the process and there's no equivalent language in CBT for this notion of critic and self-shame? And so that's why, rather than having a comparison group of CBT working with shame, what you do is you have shame work as and then you set the person up as their own control. And the control group is no treatment rather than an alternative form of treatment. And then he brought up possibly doing psychodrama, which is a more dynamic kind of approach, could possibly do that, because then you zoom in on the notion of critic and shame, right? Self-criticism and shame, and the approaches that exist to reduce unhealthy maladaptive shame, which is well established by the literature that excessive shame, maladaptive shame, is related to too much criticism, which then is related to psychological distress. Yeah. And then
I can explain if that my question doesn't make sense.
Yeah, please.
What I understood what you were saying is alternative methods as another variable to establish the efficacy of one over the other, correct? And that's why I love you guys' work here. You're far beyond most, where we're just looking at effectiveness. Does it work or not? You're looking at efficacy. Alhamdulillah. I'm only familiar with TIIP from what I learned from you, and I read your book, of course. And from what I understand, the role of the qareen, right? The qareen, the one we'll be arguing with on the Day of Judgment. I wonder if the empty chair technique can be modified in the sense that you're actually speaking to your qareen, externalizing some of that shame instead of, because from my understanding of shame, it's nadam without the sin, right? So
right, yeah, exactly.
There's nothing to ask Allah for forgiveness for. So it's just
exactly
purely shaitanic in that sense. So let's just assume that since you didn't commit a sin to the qareen for whatever reason, and then just building on that concept, because at the end of the day, I mean, I'm curious. The first time I see my qareen, I'm gonna go nuts on him, right? Made me do this, right? And that's what Allah subhanahu wa ta'ala explains in the Quran. The la takhtasiman, right? Like you can't blame him or that. So if you can do that in this dunya, maybe it's a type of addressing the self-critic, but externalizing. Now, I'm not sure if that fits in the the ontology of TIIP, but the idea of externalizing to a chair versus externalizing to a qareen in the chair. And you can clearly differentiate. One is a purely Islamic approach because you're just constantly saying, well, you're saying that you're not good enough, or maybe it's your qareen whispering to you. So what would you tell him on the day of judgment if this led to, and then you insert dysfunctional behavior here, right?
Yeah. So it's interesting that you say that. I mean, it's first of all, it's definitely consistent with sort of a TIIP conceptualization, because you're conceptualizing the inner process that's happening. The only challenge I see with that is that rather than the qareen, because the idea here is not to get rid of them and to make them all bad. We do that with, let's say, shaitan, for example, and we'll say that that's why we wouldn't say, like, let's put the waswassa, and you could actually do that as creatively, and you could even use a qareen, but the goal would be different.
Of course.
So the goal is because part of the goal with the critic here is to actually acknowledge the utility of this al-wa'id fi qalbi kulli muslim, this like wa'id in every heart of everybody that feels and knows that something's off. ما حاك في نفسك وتردد في القلب, that the scratching at your heart and the feeling of hesitation. And so that is actually adaptive, right? Which is actually the definition of bad according to the hadith. And then the notion of istafti qalbak, ask your heart. And so there's this notion of, there's a part of you that just knows that this is right or wrong. And so that why that is actually healthy and helpful to you. The problem is that when it becomes aggressive, or it becomes, like the wa'id in the masjid, or the khatib who's like not only just telling you fear Allah, but make you feel so bad that you have no hope in being able to do anything, right? You're like, that standard is so high, or the criticism is so high, and this community is so bad, or you're so bad that I really have no, and that's the part of it, that there's too much being inserted in that degree that. And so we don't want to get rid of them. We actually want to create an alliance to say, look, what you're doing is character assassination. What you're doing is not helpful or encouraging, but we're not silencing it. We're just saying that we want you to give more tapered and realistic responses.
Yeah. So you have two chairs, one qareen, and what would the other be? The malak, the angel.
Are you talking about in what I'm talking about with this?
So
process, what we're saying is your internal critic. So this is like your why. And then what we're saying is this nafs, when it goes through these maratib, it reaches lawama, meaning that you're blaming yourself. It's good. Good. But when it's too much, that's not good. So there's experiencing self. I'm the person taking the beating, the blame, right? And then I feel shame for it. And then when I look at myself and what kind of shame am I feeling, then that's where there is a process of negotiation. But actually, before the negotiation, you need to facilitate an experiential process. What happens with the experiential process is that you need to actually transform, and this is a part that's with the science of emotion theory, you need to change emotion with emotion. So what you actually do here, and Abu Zayd al-Balkhi actually talked about this too, is that what you do is you take this sort of depressive shame, and then what you do is you actually make them have enough of what the person is saying. So like there's a transformation point where the person says to the critic that says, I'm feeling like, rather than he may say initially, oh, I agree with you, I'm terrible. Like I'm not gonna make excuses for what I did, okay? But that doesn't change the fact that it's still unhealthy for them. So then what we do is we say, but what did it feel like to you? Like, can you talk about what it felt like? Oh, this makes me feel so bad that I want to crawl in a hole and like die, And it's like, oh, well, that's not useful. So then when we go to the critic should be softening to say, oh, well, I'm not trying to do that to you. Like, and that's the idea, but it may not do that initially. And then what you do is you actually have the self go back and say, wait a second, like, you're not really, you have no mercy on me. Like this is, and it has enough to become irritated by the critic to push back, to
Right.
say, wait, I'm not that bad. You see what I'm saying? And so when you get them verbalizing that, it actually does this. It kind of creates this mizan, like you want to strengthen this side from the beat up, as you do to your child, the beat up person. No, like you need to stand up for yourself a little bit. Like, just, then you kind of, and then when you do that, so, oh, wait a second, I need to give you some space here to not overdo it.
So, and my point really is being creative in the actual method of doing it, because the idea is for somebody to be able to go back and forth in their own mind. The whole point of empty chair is externalizing, right? So you can deal with the unconscious stuff, and so at the end of the day, I mean, somebody could be writing the client or the guest can be writing notes on this side. That's where CBT would come in, because now you're comparing rational, relevant, counterproductive, triple filter test. I'm sorry, I don't want to, add too much here, but it's just fascinating how one idea, because it's so well rooted in your framework, it can keep growing and growing and growing. And obviously Dr. Fahad, or soon to be Dr. Fahad when he finishes PhD, that's not what he's going to deal with now, but the idea is, future recommendations could look at 1, 2, 3, 4, and that's how it does.
Absolutely. And we have this notion of using TIIP chair work in a more cognitive way.
Yeah.
So this is more when we're targeting experiential, but there's a cognitive, and I think your Qareen here is going to work best there. And that's the process of externalization. I actually think I like that idea perhaps better than say, because we had this thing of like put Waswassa in the chair.
Yeah.
But then we were thinking, you can't put Waswassa in the chair. Who are you going to put there? You put Shaitan in the chair. That's kind of scary. Right? And so there it's more of like I'm not going to take what you're saying seriously. But the Qareen idea works actually.
It's your Qareen and your future self, right? And then you could scale it for, okay, this is 5 years from now, 10 years. Why are you backbiting your future self? You're basically saying you're not good enough to your future self, And this, I mean, in my approach with CBT, it goes back to problem solving the past and coping with the future. You just gotta flip them around, right? Yeah. But anyways,
Okay. So we're out of time here, so we're gonna wrap up. Inshallah, we're well over time, but we started a little bit late, and that's okay. Thank you all for joining. That's online, and for all of our presenters, mashallah, you all did a wonderful job. Jazakumullah khair. All right, take care. Assalamu alaikum.
Alaikum salam wa rahmatullahi wa barakatuh.